For next presentation, I would like to introduce Prof. Mikkel Ostergaard, Professor of Rheumatology at University of Copenhagen, Consultant in Rheumatology and Chairperson of Copenhagen Center for Arthritis Research, Center for Rheumatology and Spine Disease, Glastrup Hospital, has multiple clinical research in inflammatory joint disease, particularly rheumatoid arthritis, psoriatic arthritis, axial spondyloarthritis, and undifferentiated arthritis, particularly regarding clinical investigator-initiated trials, diagnostic tools, outcome measures, and imaging. So, welcome.
Thank you very much. I will share my screen. So hopefully you can now see my screen, and thank you very much for the invitation to talk at your annual conference. It would of course have been a pleasure to be there, but that's not really possible nowadays. And I hope that it's going to be okay also in this way. The title of my talk is Psoriatic Arthritis and the Therapeutic Approach based on clinical manifestations. And what I'm going to do, so I just have to find my own screen here. I'm a bit confused, sorry about that. So now it's switched. So is that I'm going to talk about the recommendations that focus on this approach, where you take the clinical manifestations into consideration in the when you treat, and that will be the older GRAPPA recommendations for psoriatic arthritis, published in 2015, and then thereafter the Euler recommendations for the management of psoriatic arthritis, which are updated much more recently. So what I will not focus on, but is that there are also some ACR guidelines for treatment of psoriatic arthritis, which were published, but they mainly focus on whether the treatment or whether the patient is treatment naive or not, and we can discuss that at the end, but I will not focus on these because my title was to talk about the disease manifestations as a guide to therapy, which I think is important also. So these recommendations I will not discuss unless we discuss it afterwards. So thereby going back to the agenda that I've just mentioned. So the first, and which I felt when they came back in 2016 or where it was published, I felt they were a new approach, which was very interesting, where you divided the disease into the different domains like peripheral arthritis, axial disease, enthesitis, dactylitis, and skin and nails. And it really emphasized that the disease is a multi-domain disease, and also the fact that makes it difficult to manage and treat. I'll come back to that in a minute. Then there's also, on top of the different musculoskeletal manifestations, then there's also a lot of other things that can occur to our psoriatic arthritis patients, including, for instance, the inflammatory bowel disease or metabolic syndrome, or also an increased risk of cardiovascular disease, uveitis, anxiety and depression, and so forth. So it is a difficult difficult disease to treat optimally, and I think it is important that we consider a lot of different features when we treat our patients, both regarding what therapy they received before, also what the patients prefer and consider most important, but also different manifestations from the musculoskeletal system and other disease manifestations and comorbidities. And obviously, we should try to address as many as all those problems as it's possible at the same time point. So in that way, disease control in a comprehensive way and is important. So focusing on first peripheral arthritis, according to these, mentioned that NSAIDs and steroids are to some extent recommended if that's enough, but in principle, but particularly conventional DMARDs like methotrexate, so salicin leflunomide, and TNF agents were strongly recommended. It should be mentioned that these guidelines are old. They are from 2000, published in 2016 and made in 2015. And at that time point, there were several of the drugs that we have on our market today that were not yet approved in different parts of the world. And they are mentioned, you could say, with a gray color on the left, like, for instance, the Premilast and IL-17 inhibitors. There has been more recent data, and that will also be shown when we come to the Euler recommendations. But overall, that was what was recommended. And for patients who then failed the DMARDs, that you should use Premilast or biologics mainly, while other mode of actions were not really recommended at that time point, only conditionally. And that has changed, obviously, over the years. Then, again, switching a biologic would lead to changing to another. Then there is a different approach, which is an actual disease, as you know, where NSAIDs are recommended together with physiotherapy, but where there are no evidence for having an effect of conventional synthetic DMARDs. However, it should be mentioned that the amount of studies that look at actual psoriatic arthritis is very minimal. At this stage, there were none. There's recently been a secukinumab study where it was shown that BASDI and other spinal pain and other features, also MRI, improved in patients with psoriatic arthritis were treated with this drug, but at this stage it was not there. So the what was recommended there was NSAIDs followed up by TNF inhibitors, and of course combined with physiotherapy. And that if you had problems or it didn't work, then you had to switch therapy. Regarding emphysitis, which you could say traditionally, at least in my country, has been an area which has received less attention than the drugs, and particularly it's also been shown less attention in clinical trials than the joint disease, and because most of the patients that are actually included in clinical trials traditionally are patients with polyarthritis, which are not so frequently the patients where emphysitis is the largest problem. But in here, it is said that NSAIDs are the first line therapy. There is some, as it says down here, there is some data that suggests that corticosteroid injections are a good idea. They work fairly frequently, but there's also relapse quite frequently. So it is considered on an individual basis without any clear evidence for long-term efficacy. And particularly the conventional DMARDs like sulfasalazine and other DMARDs are not proven effective. On the other hand, there are good data from biological therapies like TNF and at that site ustekinumab, and there are also now data which was that from a Premilast and secukinumab, which was not published as papers, then only as abstracts. Then dactylitis, the sausage fingers and toes, then conventional DMARDs and steroid injections are considered as a first step based on some data showing evidence for improvement there. There's also efficacy data for biological therapies at that time point, but and that's why that's ustekinumab and TNF inhibitors. That's why that is mentioned here with black color in the graphic. Then there is the skin disease and the nail disease, which I won't go into detail with. But again, many of our patients are not having that severe skin disease or nail disease, but some do. And it's important that we know how to handle them as well. But even though it's obviously mainly the dermatologists that take care of this, but it's mentioned that topical therapy and phototherapy and DMARDs are those that can be used, and that at later stage biologics can be relevant as well. And the same with nails. Then moving into the Euler Recommendations from 2019, published last year. And they were in many ways quite similar to the recommendations that were published previously by Euler, but they exactly made an increased focus on the fact that you should consider the individual musculoskeletal manifestations in order to provide the best possible treatment to the patients, which is obviously the overall goal to maximize, as it said at point D here, maximize health-related quality of life, relieving symptoms, prevention of structural damage, and normalizing function. So there is a change, you could say, following the line that has been set out by Graham, and I think that's a good thing. But overall, the overall principles of how we should treat is not different. We should try to reach a target of remission, or alternatively, if not possible, instead low disease activity by regular assessment. Clinically and and thereby also based on that do appropriate adjustment of therapy. NSAIDs could be used to relieve musculoskeletal symptoms, and local steroid injections could be considered, while systemic glucocorticoids is not generally recommended. It could be used with caution and lowest effective dose, but not as a general principle. And when you then move on, then the most important difference from previous recommendations, there was these peripheral and ancestral and predominantly axial disease. Then it's been divided into one more category, the oligoarthritis and polyarthritis groups. And the amount of data we have from trials on oligoarthritis patients is much less than what we have in polyarthritis. And what it is said regarding the joint symptoms here is that a conventional DMARD has been shown to work in polyarthritis, and methotrexate is frequently used and also having the advantage of working also on the skin well. While in those patients who have mono or oligoarthritis, there is not really that much evidence for conventional DMARDs use, and therefore it said it should be considered, which actually means that you could think of not doing it, not giving it, because it's not really necessarily effective. And that is particularly the case if you have poor prognostic factors. Then you should, in oligo and monoarthritis, go on to the next level, which I come to in a minute. And poor prognostic factors here is considered many joints, structural damage, elevated ESR or CRP, dactylitis, and nail involvement. Then what should you do thereafter? You should, if the treatment does not work, either the conventional synthetic DMARDs in polyarthritis, or if you skip that step, then you should consider using a biological DMARD, or you should actually, it's not said you should consider it, you should start it if there's enough disease activity. you could say it could be both TNF IL-17 inhibitors and IL-12/23 inhibitors, and they are considered equal here. So, and that's an important difference also from previously, that there's no preference for TNF inhibitors. It's considered equal, the three different pathways with different drugs as indicated with black, green, and red here. What then if this does not work? So what is the role of other therapies, just like as JAK inhibitors and Apremilast? And what it is said here is that they may be a role, or JAK inhibitors may have a role, and could be considered in case patients has received at least one DMARD and has failed that, or if it's not appropriate, then that's reasonable to use, also because there is obviously data that have documented that JAK inhibitors of different kinds are effective. Apremilast or PDE4 inhibitor may be considered, but only in patients which have mild disease with an adequate response to a conventional DMARD, and where it's considered, where you don't consider they are active enough to be where to make a BDMARD or JAK inhibitors appropriate. So in summary, regarding the updated Euler recommendations, it does say that you can use NSAIDs and local glucocorticoids according to, you could say, the individual patients, but that the main therapy depends on what disease manifestations you have. Is it polyarthritis, oligoarthritis, enthesitis, or actual disease? And if it's polyarthritis, then you should rapidly use a conventional synthetic DMARD, and their methotrexate is particularly preferred if there's psoriasis. If it's oligoarthritis, then you can consider it to use conventional DMARDs. If there's enthesitis or predominantly actual PSA, then there's no indication for conventional DMARDs. There's no proof that it works, as also stated in the GRAPID guidelines. And as a next step, therefore, you would turn into the biologics, where all the three treatments are considered equally regarding the joint manifestations, while the dermatological data suggest or show an even higher clearance of psoriasis with IL-17 and the IL-12/23 inhibitors. Next step, JAK inhibitors. Apremilast can be used for mild disease. There is suggested to switch if there's no effect. And one thing I didn't mention, which is not related to disease manifestations, is that you could consider to taper, reduce dose in patients which are sustained remission, but it would be nice to have more scientific data on the exact approach for doing that. So in summary, not saying it all once more, just saying that the treatment strategy in psoriatic arthritis, as reported by GRAPID and also by Euler, is that it should be guided by the clinical manifestations, and thereby we need to assess all these manifestations so that we can treat the patient as optimally as we can. And with that, I'd like to thank you for your attention and go into discussion if requested.